met him or received a letter from him already. He's a pain management and consultant anaesthetist at Leicester Royal Infirmary and specialises in all sorts of pain management, everything you'd expect, but particularly in children as well. And he offers a service at Spire for children over the age of 3 and also at the Leicester Royal Infirmary. So that's a fairly unique service, I think. I'm right in saying in the Midlands from an MDT service. I think it's the only one of its kind. So without further ado, over to Dr. Vasu.
Thank you, Phil. Thank you, Jenny. I'll just try to share my screen first. I hope you can see my slides. If there is any problem with the audio or video, please let me know. Good evening, all of you. Thank you very much for coming this evening, and I hope I can keep it interesting, this talk. Especially with the busy work schedule. I know it's very difficult to come at 7:30, so I'll try to keep it as interesting and as succinct as possible. So I'm going to talk on pain management in long COVID syndrome. We all know that long COVID syndrome is quite a new entity, and there is lots of doubts, questions, and still lots of research are going on. So I'm going to present some evidence about this. As Phil introduced, I'm a consultant in pain medicine, both in the adult side in Leicester General Hospital, as well as in pediatric in Leicester Royal Infirmary. And I do both adults and pediatric in Spire Leicester Hospital. I thank you all for giving me this opportunity. So let me see whether I can move the slides now. So this evening, I'm going to talk for the first 40-45 minutes and then leave the rest of the time for questions. I'll try to keep it as interesting as possible. I'm going to first talk about the problems that persist after the COVID infection. I'm sure you are experts in COVID infection, seeing lots of them in the community. So I'm going to talk about what problems persist after the acute stage, and is there any guidelines with regards to managing these patients. The second part would be about pain management in this condition, and what is the evidence for pain management, and what you can do in the community yourself. The third part is if you refer, what we can do. So that is how I'm going to divide these things. It's a dry topic. So I'll start with a small joke. It's difficult to talk in front of the Zoom. Of course, we have got used to this, but I'll start with a small joke or a story because we have not been to any holidays for more than a year because of all this lockdown. So I'm sure you all are in the same status. So I told my wife, like, once all this vaccine and other thing comes, maybe in Easter or in summer, I can take holiday for the whole family anywhere. So we had a map on the wall, and I said, gave the dart to my wife and said, you can put the dart on the wall. Wherever it goes, Easter time, we will go there, any part of the world. So apparently it turns out after the dart was thrown that we are going to spend the 2 weeks in Easter behind the fridge. So jokes apart, I will go to keep it simple. So chronic pain is a very, very difficult entity. I'm sure you would see lots of heart sink patients in your real practice. What you see is the iceberg. What we see in the hospital is the tip of the iceberg. So I'm sure chronic pain patients demand a lot. They are depressed, they are frustrated, they are anxious. They think that nobody else believes them, and they are difficult patients to manage. I'm sure you see them every day. This is Edward Munch. Existential angst. So typically our chronic pain patients are depicted like this, as you see in this nice picture. So is long COVID syndrome a real entity? Many people can question, is it a psychological condition, or is it a psychosocial condition, or is it a real biological condition? So lots of questions are there. So I'll start with the COVID pandemic and then tell about a bit about pathophysiology or the cause for this long COVID syndrome. So we all know about COVID-19 pandemic caused by the virus, coronavirus 2, identified first in Wuhan. And then we know that in the acute stage, we see lots of symptoms, fever, cough, breathing difficulties, tiredness. But the most important thing we know is loss of smell and taste, which distinguishes it from many other viral conditions. And we are, of course, seeing many new variants, as we all know. I'm not going to go into those parts. But as I said, if you look at the screen, the most important thing is smell and taste dysfunction in the acute stage. So we know about that. With regards to pain after illness, there is huge amount of evidence and meta-analysis available with regards to people who come out of intensive care, even before this COVID started. So when you see patients who have spent lots of time in intensive care, and when they are discharged, we see that they spend times recovering from this. Many of them can suffer with myopathies, neuropathies, and this is a very well-known condition. So post-intensive care syndrome is an already existing condition, which we knew even before the COVID. And we know that in these patients who spend significant amount of time in intensive care, they have cognitive problems, physical problems, psychological problems, and chronic pain is a big problem after patients who are discharged from intensive care. And there is a huge evidence to say that there is a population of 14 to 70% who suffer with chronic pain after long-term intensive care, and their quality of life and ability to work is significantly affected. We see this very commonly in multi-organ failure or adult acute respiratory distress syndrome, who suffer with significant traumatic experience in intensive care. So that is the knowledge before all this COVID started. COVID changed all these things, and we have come with a new term called as post-COVID syndrome or long COVID syndrome, where people still suffer despite after the acute stage has gone. And the incident is quoted as anywhere between 1 in 5 to 1 in 10. That is the incidence of people who are going to suffer and who are still hiding in the community and who will be presenting to you once all this acute stage goes on. Many of these people will have problems with fatigue, tiredness, pain, shortness of breath. Serious long-term effects have been described by World Health Organization, and they do suffer with mood swings and mental health problems, and there is huge evidence and meta-analysis to show this. Obviously, this is a BMJ practice pointer, and if you look what Trisha Grenak has said, approximately 10%, if you look at the point number 2, 10% of the people suffer with prolonged illness. So there is evidence to show that these patients can suffer with problems. We all keep saying as doctors that most of them are going to recover within 1 or 2 weeks, and they don't need any medical treatment, supportive treatment, many of them recover. But if you go to the community and look into the Facebook, social media, and lots of things, you can see that there is a big population who are suffering, who can't get access due to the present practical problems. There are incidences, and as you look in this picture, they do suffer with chest pain, tachycardia, anxiety, traumatic events, sleep-related problems, and there is huge amount of things going on in the community. And because of the restrictions now, these people are not presenting to the healthcare, many of them, and they will present once this acute stage goes on. It is a big burden. It is going to be a third wave after the second wave goes away. Main problems that we are going to face both in primary care and secondary care is fatigue, joint and bone pain, palpitations, breathing problems, headaches, and insomnia. Lung-wise, irreversible pulmonary scarring and dysfunction can affect significantly, even up to 6 months or longer. Cognitive dysfunction, 1/3 report neurological symptoms. People can suffer with hallucinations, fear, confusion, agitation. There are lots of studies which have shown that delirium is a very, very big problem. Nearly half of them can suffer with neurological manifestations. Is there evidence for what I am saying? Yes, there are lots of papers. I'm sorry for this busy slide, and I'm not going to go through all of them, but I will send a handout. But as you can see, studies from all over the country, either it is from London or Wuhan or Rome, every study says that there is a significant amount of population who are suffering with fatigue, dyspnea, and pain-related problems. Variety of symptoms are prolonged, and there is quite a spectrum of symptoms in this condition. If you look from this big Italian study, the commonest symptoms are fatigue and shortness of breath. But as time goes on, pain takes a bigger problem, like joint pain, chest pain, widespread pain, muscle pain, and it can become a big problem, and headaches, of course. So there is a big incidence of these problems that are going to affect your day-to-day practice in near future. Delirium can happen due to a variety of causes. Many of these patients come to the hospital, they are isolated, they wear PPEs, the healthcare professionals wear PPEs, they are not allowed to see the family, they are disoriented, and many of them can go through intensive care, long-term ventilation, sedation. They can suffer hypoxia. So it could be easily underdiagnosed, the incidence of delirium in this population. Why do these people get cognitive dysfunction? There are a variety of theories which have been proposed, but the main risk factors are comorbidities. As you can see on the left-hand side, if a patient has diabetes, obesity, high blood pressure, COPD, they are at high risk for cognitive dysfunction. And we can make it worse, as you can see on the right-hand side, other corner, like prolonged sedation, medications, and isolation can make the delirium worse. The main pathology that has been spoken of is based on microvascular level, like pulmonary reasons for hypoxia. It could be the endothelial breakdown, pulmonary edema, which is very common with the cytokine storms, vascular pathologies, and neurological pathologies. As we said, there could be a microglial activation in the histological level, oxidative stress changes, and it can cause vasogenic edema. These are the reasons proposed for cognitive dysfunction and functional decline after the COVID infection. What are the risk factors? This paper tells that there is a significant amount of risk of chronic pain after the COVID syndrome. And if you start on the left-hand side, there are challenges in rehabilitation. Already the services are restricted. For example, our NHS pain clinic has been closed and we are all moved to intensive care. Even today, I was working all day in intensive care because the pain services are closed because there is a huge demand of healthcare professionals in other areas. So rehabilitation services are going to suffer a lot and the demand is going to increase. That can cause more fatigue and tiredness. Acute pain and high risk of acute pain. That is the second thing I'm going to talk about. If the patients are suffering with severe pain during COVID syndrome, if they have significant breathing difficulties, these people will suffer with long COVID syndrome. The risk is quite directly related. If there are comorbidities, as we said, they can suffer with problems. Intensive care patients have a high risk because these patients don't know where they are. There is a risk of prolonged ventilation, immobility. We use lots of muscle relaxants, sedation drugs. For example, at present in Leicester, we have significant number of patients who have come from London, Watford, and other areas, Romford, because of lack of beds. So it has been very difficult to orient them, and the family are not allowed to see because of the PPE and other things. So there is a huge problem with the risk of delirium, and that can cause chronic pain. Neurological insults. If there is initial infection and cytokine storm causes neurological problems, they are at high risk for chronic pain. Added to that, mental health burden. As you all know, chronic pain is significantly related to mental health problems and they both are linked to each other. So if they had significant post-traumatic stress, that can lead to chronic pain. So we need to keep an open eye for that. What about the role of opioids in acute stages? Is there a link to that? There are various studies, and Lambert has proposed that people who are on high dose opioids, we clearly know by British Pain Society guidelines that people who are on more than 80 to 120 milligram per day of morphine equivalent, which is not a big dose if you consider the weak opioids and strong opioids, they are at high risk for immune suppression. So the proposed theory is that immune suppression can lead to long-term long COVID syndrome. So as we said, COVID itself causes immunosuppression, opioids can worsen it. So the consensus panel says that the opioids could cause worsening and they can, patients who are on high dose opioid can have long COVID syndrome. But there was another study, European study, as you can see in the slide, who have looked at drug abusers, and they didn't find a high incidence in drug abusers. The reasons are a bit controversial. Maybe it is because they are all isolated and they are not exposed, we don't know, or maybe methadone can be protective in some reactive oxygen species activation, so we don't know. So the theory is still discussed a lot, but keep an eye on patients who are on high dose opioids. They might be at risk for long COVID syndrome. That is what we can say. So that's the introduction. I'm not looking at the chat section here, but I will come back to your questions. If there is anything, keep typing it. Phil is going to look at the questions and put it to be at the end, I think. Next, I'm going to talk about, is there any guidelines with regards to long COVID syndrome? That is the second part of my talk. I'm going to touch on three different aspects here. Number one is, what is the NHS plan with regards to long COVID syndrome? Number two, there is a nice guideline with regards to long COVID syndrome. I'm going to touch a bit on that. And then I'm going to talk about myalgic encephalitis or ME association guidance, because they are the one to come out with guidance very quickly, as we would expect with regards to fatigue and pain. So the NHS England clearly has recognized that long COVID syndrome is going to be a big problem now. And Sir Simon Stevens has come out with a 5-point plan. Number one is the NICE guidelines. So he proposed for a NICE guidelines, and we already have that NICE guideline. Number two, NHS has suggested an online tailored rehab program. Number three is COVID assessment services, and there is a bit of funding. I don't know whether that will be enough, but some funding has gone to most of the respiratory units to look at long COVID problem. NIHR funded, the National Institute of Health and Research have funded some research on long COVID, and it has been given as a priority. And there is a task force being set up on this. So the higher authorities have recognized that this is going to be a problem and actions will be taken, they have promised. So with regards to post-COVID syndrome, the NICE guidelines have given some idea about how we should be managing, along with the Scottish guidelines and Royal College of GPs. They have come out with a NICE guideline in October 2020, and signs and symptoms which last after 12 weeks is what their scope was with regards to this NICE guideline. So this is easily available online if you search it, and it was put at it came out in October and it was published in December after consultations. NICE guideline 188 is the code for that. So they have defined in 3 ways. Actually, they said, like, rather than one, it might be 4 different terminologies we need to know of. Number one is acute COVID syndrome, which could last up to 4 weeks, which is what most of us see in the hospital and in your primary care and look at symptoms. But symptoms can go on, especially the respiratory symptoms can go on from 4 to 12 weeks. And this is called as a ongoing symptomatic COVID. So that is, symptoms are continuing more than what we would expect. Post-COVID syndrome is the one which lasts more than 12 weeks later. But there is some patients who have like ongoing symptoms from the initial symptom which has not settled, and the post-COVID pain and fatigue taking over, and that is termed as long COVID. There is a bit of controversy between post-COVID and long COVID, and in clinical terms, we are using the same term for both the things. So post-COVID and long COVID are more or less same, but long COVID has more symptoms. That is what I can tell according to the NICE guidelines. So what does NICE guidelines say? I'm not going to go through the whole guideline and bore you in the evening time, but I'll give you a small summary of the synopsis of the guideline. So what NICE guidelines say is, if the patient comes with symptoms related to long COVID, they need to be offered initial consultation. It could be a web-based platform or in person. They have advised using screening questionnaire, especially with regards to mental health status and clinically assessing them. And vulnerable groups and underserved groups allow extra time, especially people who have autistic spectrum, mental health problems. They might need to be allotted more time. That is what NICE has said. And in high risk groups, the follow-up is important, not just managing them, but maybe arranging an appointment 6 weeks after discharge and making sure that they are managing well and the yellow flags are not continuing. So NICE guidelines suggest this way of assessment. They are asking us to look at holistic patient-centered approach, comprehensive detailed history, and then assess in 5 different domains. Number one is physical assessment. Is there a breathing problem? Is there a cardiac problem? Is there postural hypotension? Those sort of things. Number 2 is cognitive. Does it affect the memory and the day-to-day functioning neurologically of the patient? Because that is going to be a big problem. The third thing is psychological. It is going to cause more ongoing anxiety, fear, depression, and stress. Number 4, is there a need for psychiatric referral? That is the 4th thing they have suggested. And the 5th thing is functional ability. Are they able to function? They have not given exactly what sort of scores or scales you should use, but they have given some examples in the guideline. Do they need investigations or referral? NICE guideline says that if they have hypoxemia, lung disease, chest pain, or multi-system organ involvement, you might need to think about this. Blood test, they have asked to rule out common things like full blood count, USNEs, CRP, and then for long-term markers, they have suggested septic markers like ferritin, B natriuretic peptide, and thyroid function test. The exercise tolerance, any exercise tolerance test, they have not said that you have to use this, whether they can walk, sit, to stand, anything. Pulse oximetry might be important in respiratory problems. Postural symptoms are very common in long COVID. And if the symptoms don't settle, they have suggested X-ray, chest X-ray, and psychiatric referral or assessment wherever the service allows. Management, they have given only broad principles because, as you know, NICE has recognized this is going to be a new spectrum of problem, and each patient will be totally different from symptoms, what it presents with. So self-management is the key. Multidisciplinary assessment wherever possible, specialist care for specific complications, especially if there is a respiratory or cardiac problem, phased return, and follow-up and monitoring. I know it is broad topics, but they have given a bit more detail in that. The last guideline that I'm going to talk in the second section is the ME guideline, or myalgic encephalitis. They always talk a lot on are supporters of the chronic fatigue syndrome, and they have been very wise in coming up with a guideline even before the NICE in September of last year. So they have recognized that there are nearly 60,000 people who are suffering, but it might have gone up significantly now. If we easily recollect that the numbers are going to touch 4 million people who have been infected in United Kingdom. So if we are talking about 10%, nearly 400,000 should be suffering with long COVID. That is the numbers what we are talking about. Of course, all these patients are not going to come and present to us. We might be seeing patients who are going to come out and express their symptoms or who have severe symptoms. And COVID tracker app has said that 12% report symptoms after a month. So which equates with the BMJ article, which I showed in the front, like 10 to 12%, 10% is the average number. And fatigue is the main symptom that ME Association have audited. And they have suggested like looking at your COVID recovery app, the NHS app, which is given for rehabilitation, which is online available free, long COVID assessment centers, which the government has come out with, and Leicester has a respiratory unit, which has a long COVID assessment center, and pain management has been stressed by these patient groups. So it is a wide variety of spectrum, and I'm not going to give a mathematical solution or a bullet point to help with your practice. But as I said, these are to create awareness that these symptoms could present in your practice, and you are going to see more and more of these patients in your practice in the future. So management wise, this is the last section I'm going to touch. I'm going to talk about 5 different points. Number 1, fatigue. Number 2, breathlessness. Number 3, mental health. I'm not an expert in all these things, but in my day-to-day practice, I've already started seeing long COVID patients. And even in pediatric population, we are seeing these patients. I do advise them because it is easy to advise these 3. There are resources available. The Royal College of GP as well as the NICE guideline directs to a few resources, which I will be talking about that. The 4th one is my specialty, which is the pain management. So I'm going to suggest what sort of things you can do and touch a bit about a few medications, and then when to refer, and if you refer, what we can do. So that will be the 5th part of this talk. So fatigue and breathlessness, this is going to be a major problem, more than the pain in the first 6 months after the problem. After 6 months, fatigue and pain will take over. And that is what I propose, but it might be different. We don't know. It is too early to say. But fatigue wise, the NICE COVID platform gives pacing strategies, simple strengthening exercises. Maybe if they are not settling, referral to a physiotherapist in the community to look at core muscle strengthening exercises. That is what is the key to recover. Breathing exercises, there are lots of things, but the main thing what we propose in the pain clinic is deep abdominal breathing. Many of you would be aware with that. So taking breathing through the nose and breathing out through the mouth. It's easy to say this, but patients don't practice it. So what I tell them is just sit in front of a mirror at least 10 minutes in the morning, 10 minutes in the evening, and do this, practice these exercises. There is this on the right hand side, you can see a rectangular window shot of shape. So patients can breathe in for a short time, breathe out. So just follow the pattern and go all around is what we say. So breathe in, breathe out. So take more time to breathe out. If patients are happy, then we suggest the Breathe to Relax app, which I have shown on the bottom of this. We propose this to many of the chronic pain patients, not just COVID pain alone, many chronic pain patients. The reason is it's a free app developed by American Health Research Association, and it is free to use, and it is very good. I use that personally myself, and it gives like pictures and representing breathing, and you can change the inspiratory time, the expiratory time. There are videos on physiology behind the breathing strategies. So I think spending some time with regards to breathing exercises is a key in these patients with regards to fatigue as well as breathlessness. The second thing is mental health and mood. So don't underestimate this. This is going to be a huge problem. Already isolation, loss of income, loss of work, all these things could be adding to the mental health. Added to that, getting a long COVID syndrome is going to worsen the status. We are going to see lots of social problems related to this in future. So tell the patients to be kind with themselves. They've gone through quite a traumatic event and they have come out. And the main thing is to connect with other people and establishing a daily routine, because many of them may be bedridden and then they will find it difficult to recover. We teach them that hurt when they start to move is not going to mean harm. So that is the key word in telling them to stay active and pace it very, very slowly and gradually to recover. They have had quite a significant COVID-related myo and neuropathy, so it will take time. But if they are on the right track and if they pace themselves, they can recover. Third thing, memory and neurological problems, maybe reducing the distraction, making notes and planning. I think one of the nurses and colleagues can educate them, because that will be a big problem and people will be worried about their memory problems and the neurological conditions, especially with the cognitive problem. So I touched a bit on all these things. If there are questions, I can answer at the end. But pain, that is going to be a big problem, especially in long-term COVID, like long COVID syndrome, which is going to last more than 6 months. Pain is going to be a huge problem. So education-wise, what you can do in the community, flexibility exercises, referring to a nice community physiotherapist, yoga, tai chi, mindfulness, and stretches. Maybe you can direct them to a few websites, strengthening exercises. We always in our pain management program suggest about climbing stairs, lifting weights, resistant bands. So each patient might fit a different thing, but the main goal is to start moving and pace. That is the main thing with regards to managing the pain. Obviously, there are two things which are important with regards to pain management. Number one, if you see some yellow flags, like if they are not moving and if they are restricting their social activities, referring to a physiotherapist in the community first to start with, and maybe counseling services because they have gone through significant trauma, either some CBT based approaches or Let's Talk or IAPT services in the community. And obviously, these patients will need this help to engage them back into the society. With regards to pain management, pharmacology plays a small role, but whenever you start some medications, make sure you are reviewing them, because we don't want, like other chronic pain patients, to end up with a huge dose of opioids at the end. So using a biopsychosocial model, assessing whether the medication works, using a multimodal strategy, especially functional restoration using physiotherapy is a key in these patients. Maybe complementary therapies, although the evidence could be debated, acupuncture and TENS plays a big role in these patients to avoid medications and their side effects in the long term. Analgesic evidence is significantly limited in chronic pain conditions. You can use simple analgesics, but try to avoid opioids is the key, because opioids might help, but like in any other chronic pain, once you start opioids, you might end up with opioid related problem rather than pain relief. There might be a role of neuropathics. So if it is not subsiding and you're seeing more sort of neuropathic pain symptoms, burning, irritation, and dysesthesia type symptoms, then you can prescribe neuropathics as per the NICE guideline. NICE guideline for neuropathic pain says that you can try anything starting with amitriptyline 10 milligram or gabapentin, pregabalin, or duloxetine. I would start with amitriptyline because it is cheap and it does the trick. Amitriptyline, gabapentin, pregabalin all have a number needed to treat of anywhere between 4 to 6. So starting with a simple agent is easy to monitor, and then pregabalin or gabapentin. I would avoid duloxetine if possible, because I've seen more sort of mental health and hallucination problems with that. So simple neuropathics and a 4-week trial. At the end of the 4 weeks, if it has not helped, maybe you need to change or add other medication or stop it. Because if you're going to give this neuropathics for 3 to 4 patients, only one of them is going to get 40 to 50% relief. So the rest we might have to wean and stop them. So that's with regards to medications. If the patients don't respond to these things, and if their functional outcome is limited, they are not going back to work, their quality of life is restricted, there are yellow flags. Yellow flags are like signs of catastrophization. So patients being afraid of pain and not moving, they have a fear that they are going to die or this is not going to get better, those sort of fears. These all come under yellow flags. And if they have this chronicity markers, yellow flags suggest that these patients are going to go into chronic pain. And if you have that and there is no improvement in the care, maybe you should think about referring to pain clinic or rehab services. So apart from the medications, what we have discussed already, are there any other novel treatments? Yes, we do a lot of therapies, which I am going to discuss in the last part. But as I said, the evidence is extrapolated from evidence for chronic pain. So evidence is significantly limited, but we do practice this in resistant patients. And our experience comes from using these techniques in other chronic pain states. And that is what I'm going to suggest a few things. Lignocaine infusions we use a lot in widespread pain like fibromyalgia, chronic widespread pain. And lignocaine is a very, very simple drug. We use that very commonly, and both in Spire as well as in Leicester, we do practice lignocaine infusions in chronic pain like fibromyalgia type pain. So there is some evidence to say that lignocaine has some benefit in COVID-19. So what is the evidence? So we all know that the cytokine storm happens because of neutrophils. That is the main thing which causes phagocytosis. and oxidative burst. The theory proposed is that the neutrophils change and cause something called as nets, which is like neutrophil extracellular traps. I'll show a picture in the next one. So this is like a trap being formed when the virus causes a reaction, and this trap sends the cytokine storm. It starts the cytokine storm. So the patients who have cytokine storm, we know that they end up with significant COVID or long COVID pain. What is the biomarker for this? There is a paper to show that citrulinated histone 3, CYTH3, if it is high, that means that the patients have had high amount of neutrophil traps or nets. And these nets can be reduced by lignocaine infusions. That is why I'm going to talk about that. And these nets are the main key with regards to the cytokine storm. So they form like net-like structures, and it works by two different chemicals, which I'm going to show in the next thing. I'm sorry for telling complex things, especially in the end of the day, but I want to prove that there is some evidence to show this. So already we have lots of papers to show that nets can be reduced by lignocaine. How it does is lignocaine blocks two important chemicals, which I'm going to show in the next slide, called HMGB1. It is a transmitter in the NETs process, high mobility group. And there is another chemical called granulocyte colony stimulating factor. These two can be blocked by lignocaine. And that is how it causes anti-inflammatory effects, and it can help in long COVID pain. So this picture shows the small neutrophil here, which is going to form a net later on. And the net is formed by these two chemicals, HMGB1 or high mobility group 1, which links to the toll-like receptor. So once this links here, and once granulocyte colony stimulating factor links to the neutrophil, it forms lots of nets or neutrophil extracellular traps. But the lidocaine or lignocaine infusion can block these receptors. So that is how it works, and we use this commonly. And there are other chemicals like colchicine, which rheumatologists use a lot, and some enzymes which are used in cystic fiber. They are very costly. These all have been proven to reduce the nets and long COVID syndrome, both in acute stage as well as in long-term pain stage. I don't have experience in colchicine, but maybe rheumatologists are doing some research on that. But lidocaine, we do have huge amount of experience based on our chronic pain interventions. Is there evidence to prove that? There are lots of papers. I'm not going to go through that. But even before the COVID, they have done lots of RCTs or randomized control trials in various cancer surgeries, immunological conditions, and they've shown that there is significant amount of evidence to prove that lidocaine reduces the nets or netosis. That is the process it is called. And it can reduce the immunological reactions related to long COVID syndrome. There is a dose which has been proposed. We use quite significant amount of higher dose than this in chronic pain. And there are other ways how the lignocaine can help, both in nebulized use in acute stages. It does have antibacterial action. It does have repolarization. There are lots of other effects which are proposed. But the main thing is removing the free radicals and cytokine storm. So basically, the summary, what I'm saying is, yes, lignocaine infusion can be a tool in resistant cases, and we use it a lot in chronic pain already. And this can have a role. The dose and how long and is it a meaningful clinical benefit is still research, to be honest. But there is a research to prove that there is some amount of evidence in other chronic pain conditions, and we're using that evidence and extrapolating it. So that's with regards to widespread fatigue and tiredness and pain. Headaches are going to be a big problem. As I said, long COVID syndrome has a significant amount of headaches, and that has been shown in various papers. In chronic pain clinic, we do lots of injections for headache. One of them is greater occipital nerve block. We block both the occipital nerves using ultrasound guidance. And it is one of the simple procedures that we do, both in Spire as well as in NHS. And that can help with headache related problem if it doesn't settle to simple things. So best thing is to try simple things. And if it has not helped, you could refer to us and we can do these injections. We also use Botox injections in migraine. And this could help in long COVID syndrome, because the way the Botox works is by inhibiting a few pain-releasing transmitters like SNAP proteins, what we say. The SNAP proteins are SNAP25 and synaptobrevin. So I'll show you another picture. So what it does is, whenever there is a muscle contraction, the synaptic vesicle releases the chemicals. And these three chemicals, SNAP proteins called as SNAP25, syntaxin, and synaptobrevin, cause a fusion and complex, and that acts on the neurotransmitter release. So if we inject Botox, this process is stopped, and that is why there is a bit of muscle relaxation. And more than that, this is a pain releasing neurotransmitter. So the pain pathway is stopped. NICE guideline has shown that Botox has high level of evidence in migraine if other treatments have been tried. So it is not the first line treatment. We should have tried at least 2 different triptans or other medications, and the headache should last for more than 15 days. That is for Botox. We do use it in COVID related headaches also, because the mechanism is the same. It stops the neuropeptides in the neurons. The last thing is we do a variety of other injections. Anywhere, wherever there is pain, we can block it with a needle. But how long it lasts and whether it lasts in each and every patient is different. But if you're stuck with problems with pain, and if it is not improving with other medications, yes, there is a role for regional block using various techniques in different parts of the body. So we can do that. So I'm coming towards the closure. So I will tell with this paper, because this has the highest level of evidence. This is a paper, I know it is a bit busy slide, but I'll try to keep it simple. This is a paper from Wuhan, China, where the initial thing came. And this paper came just 2 weeks before or 3 weeks before. So they have looked at 6-month consequences, because all the rest have looked at 30 days, 3 months sort of thing. But what will happen after 6 months is what we need to concentrate on. 6 months after discharge, they have looked at nearly 2,500 patients. And of course, there was a significant amount of patients who were excluded. But this recent paper says that this is going to be a big problem. And they conclude, what do they conclude? Of course, we do see lots of breathing problems and fatigue and other things. But after 6 months, after COVID, the main problems are going to be 3 things. Number 1, fatigue or muscle weakness. Number 2, sleep-related difficulties. Number 3, anxiety and depression. So all these 3 things are going to cause chronic pain. And this is going to be a big problem as per the evidence that I have given. If you want to learn more, the Royal College of GPs have a 30-minute small CPD thing, which is, it took me only 10 minutes to do that. So you can try that. It's very good, free and easy to access, even if you're not a member of RCGP. It was very interesting. And they have some case reports also. I'm going to stop here, but before I finish, I want to just show you a different video. If you have time, I will just take 2 minutes to share that, if you don't mind, and then I should be finished, if you don't mind. So it is quite an interesting video. I'll try to play this, if you can hear that.
The sound isn't coming through very well, Dr. Vasu.
Oh, okay. Is that better or no?
No, I can't hear it very well at all.
Okay. Hold on. Yeah. I think I'm having problem here, but don't worry. I'll send you the link, I think. Just a minute. I'll stop this. I think I'm going to stop there, because I'll give you the link in the handout. It is called Long COVID Syndrome, longcovidsos.org. The reason I proposed the video, it's a nice video, it takes 2 minutes. I'll send the link through Jenny. It clearly says that there is a huge population who are frustrated behind the screen, and these patients are going to present to both primary care and secondary care later on. And these patients are saying in the social media that nobody is listening to them, and it is going to be a big problem. With that, I will stop here and take the questions. Thank you very much. Thank you, all of you.
Well, thank you, Dr. Vasu. Excellent talk as ever.